All
All
right,
right,
Sam.
wonderful. Thank you.
Huh?
At the end of the session, I will have some business just for the group, so maybe we can shut off the recording at that point. Is that okay?
Absolutely.
Wonderful. Okay, hi, everybody. Thank you so much for coming on board. So excited to see everybody's faces here. It's just wonderful. So I am going to share my screen. I am going, the screen sharing is disabled. I will shortly share my screen and
You should be good to go.
wonderful, that was fast. Okay. All right, let's see how I can do this so I actually show you my presentation slides and not my notes slides. Always the challenge. All right, give it a second. I'm gonna hit play. Okay, are we on presentation?
Yes. Yep.
Wonderful. I'm trying to make this as interactive as possible. I'm going to try to whiz through so it's not too much time, but I am excited to hear from our providers as I give the talk as well. So we'll see. So here is a PAD Basics for Primary Care Providers lecture. Again, thank you everyone for being here. We are so happy to have everyone involved. So PAD, peripheral artery disease, just some updates. So we call it peripheral artery disease now, not peripheral arterial disease. That was a nomenclature change over the last 2 years. I'm not sure why, but that is what it is. And just right off the top, I do want to mention that PVD, peripheral vascular disease, is not really a thing, but it's available as a billing code. So a lot of people put it on consults, or sometimes they say PVD and they think it's peripheral venous disease. That's not a thing either. Which again, nobody really tells you because it's actually available as a billing code. But to be clear, PAD is a thing, and that's what we're going to be talking about. And that is typically if you're sending a consult for PAD, then that's PAD, arterial disease. If you have venous disease, then you can send for varicose veins or leg swelling, but PVD doesn't equal the same thing. So I just wanted to clarify that for people right off the top. So PAD is restriction to the blood supply to the foot, and often will show up as people having pain with walking or wounds or non-healing ulcers. And here's just a nice little diagram where you can see atherosclerosis over time causing narrowing of the blood supply to the foot. Some facts. So 8 to 12 million people in the United States have PAD. And that is the main risk factors are age is one of the biggest ones, but basically anybody over 50 that have a risk factor such as smoking, high blood pressure, diabetes, high cholesterol, all of these put them at risk for having PAD. Anybody over 65, just by virtue of being over 65, they're at risk for PAD. Anyone under 50 need to have one risk factor with it for sure to consider it on the diagnosis. In West Virginia, I think we have a lot of experience with people that are younger than 50 because of all the smoking that present. I'll talk more about signs and symptoms as we go along. So signs and symptoms of PAD. So everybody talks about claudication, and I think that's the thing that most often people get educated about in medical school and in any of their education. And I don't know, Kristen, Kayla, Quentin, if you guys agree with that, that's kind of the main thing you get taught, if you get taught anything at all about it. What do you all think? Do you get much education about PAD? Just some heads, some no's. So I would say intermittent claudication is one of the biggest things. And it's weird because only 50% of people actually have any kind of symptoms. Most don't have symptoms that we know about. If you really dig into the literature, you can see that there are some things that are coming up where there probably are people that are having symptoms with PAD, but they've self-limited themselves. So they walk slower, they've changed their expectations of what they can do. So their quality of life has decreased, but it's not enough for them to actually show up and say that they have symptoms. There's also questions of whether or not there's some cognitive declines that come with it too, but that's not typically picked up. So about 50% don't have symptoms. Of the people that have symptoms, only 10 to 30% actually have this claudication that, that's what you learn about in the textbooks. It's, I walk a block and I get a cramp, a calf cramp, and then I rest and it gets better. And every single time I walk a block, that happens. And honestly, the vast majority, so 40 to 50% of people don't have those typical symptoms. And again, a lot of the time, that's because a lot of these studies were done in white men. And so that's where we get all of this literature from. Women and non-whites are actually much more likely to present with atypical symptoms. And a lot of the time it gets kind of squished together with complaints of neuropathy and other things too. So it can be a little bit difficult to tease out. Of the whole batch though, it's important to understand that less than 5% of people that have claudication, so of the 50%, less than 5% actually go on to have limb-threatening ischemia. And I will explain what that is. Here's a natural history. And this is one of the biggest take-home points for you all, is that people that have PAD are at the risk for them, since they're going to be only 5%, 1 to 5% actually go on to have a limb-threatening problem. The risk is dying of a heart attack or stroke. That's the big take-home point. The Fourier study, which looked at the fancy new PCSK9, the new injectable cholesterol drugs. So this is a fairly recent study, and they happened to do a subgroup analysis. So they looked at people just over time, so over 2.5 years, people that had either a history of a heart attack or stroke, but no history of PAD, or a patient with PAD that had either a history of heart attack or stroke or none. And the patients with PAD had more of a risk of having a heart attack or stroke within that 2.5 years than the patients that did not have PAD. So you show up in the study with a history of heart attack or stroke, you're still less likely to have another event than someone that shows up with PAD without that history. So basically the point is that this is a marker for severe disease that's gone unchecked throughout the entire body. What I tell my patients is if you can't get blood to the heart, imagine what's going on in your feet. So other way around, if you can't get blood to your toes, imagine what's happening in your heart, right? So it's the brain and the heart that's what's going to kill them. And so that's why it's so important to identify and manage. Here is the expected natural history of someone with intermittent claudication. So the patients that come in that are complaining of pain when they walk a certain distance that improves with rest. Over 5 years, the vast majority, 80%, are going to be stable. About 20 to 30% are going to have worsening symptoms, so more severe lifestyle limiting claudication, and only 1 to 3% are going to have this limb-threatening ischemia. And again, people with intermittent claudication, 20% of them are going to have an MI or stroke, and 10 to 15% will die of that. So that's why, again, important to identify. What is CLTI or CLI? And again, I'm going to guess that this has not trickled down to you all, but there has been another change in terminology. We used to use the term critical limb ischemia, CLI, and it's been changed to CLTI, which just tries to be more realistic about the picture of people that come. So usually people that show up are not people that suddenly have a critical event. This is something that's been going on for a while, and that's why they changed the terminology. But what's important for you all to know is basically someone with peripheral artery disease that has rest pain, so they are having severe pain in the feet and leg at rest. So that same kind of pain that someone that's walking will develop. These are people that have this pain constantly. So if you work out and you're like running a marathon and you get a cramp in your calf, this is what these guys are feeling at rest. Or they have a wound or gangrene that hasn't healed and it's been going on for more than 2 weeks. That's what that is. And that's the emergency patients that you need to contact about us. They're more urgent or emergent. The regular PAD diagnosis in claudicants don't have that same level of urgency. What's interesting is that about half the people that do present with CLTI have not had a diagnosed PAD, because again, we don't do a good job in general identifying PAD. CLTI has very bad outcomes. Amputation risk is about 20% at 6 months, about a quarter die at a year, again, of heart attack and stroke. And only about half of these patients even get to a vascular stringent before they end up with the amputation. So obviously something we want to prevent. And it's really more something I want to have you gotta have in the back of your head so you can identify it. But we're really going to talk more about PAD. So how to make the diagnosis. So I snagged some of this stuff from the American Family Physician website. They did like a thing on this. But making the diagnosis is really all about history and physical exam, and that there is a complicated looking guideline here, but I will simplify it. Basically, your exam. So again, you're looking for people that have risk factors. So are they smokers? Do they have high blood pressure? Do they have diabetes? Are they over 50 or have risk factors and are under 50? And what is the history that they're giving? So again, a lot of the time we're looking at, pain that is limiting them from walking. And again, a lot of that, the things to really think about, it's not radiating pain typically. It's not like, oh, starts in my butt and goes down my leg. And it's not something that gets better with positional changes either. This is something that you're exercising, walking, you get severe pain because there's not enough blood flow, and it gets better with rest. And it may not have this classic calf cramp that always gets better, but it should be reproducible with activity. Like that should be the thing that's triggering it typically. Then ischemic rest pain, a lot of the time, it really involves more the top of the foot and the foot itself. And that's just because the flow is so bad, there's so much blockage that they have severe pain when they're just resting. Obviously, any gangrene or non-healing wound in their foot in particular, something to worry about. And then the diagnosis of dependent rubor, where it looks like they have erythema of their foot, but if you elevate it, it turns white. That is another sign. And does anyone know the reason why you get dependent rubor?
Feel free to unmute or put your answer in the chat. Either way.
Put your answer in the chat. You don't want to talk. That's all right. Typically, it happens because you think about it, just that people's feet are so desperate for blood flow that gravity kind of, when the leg's down, it's like, we need blood, and it just sucks up all the blood that can come to it. So it turns like bright red when it's hanging down because your body's basically just relying on gravity. And then if you lift it up, all that blood drains down and then it turns bright, it turns totally white. That's why a lot of these patients that have real bad claudication or rest pain will sleep in a recliner with their legs hanging down. Or they may say they dangle their foot off the bed at night and it makes it feel better. And that comes with rest pain a lot of the time. It's pretty advanced when you have those legs looking like that, but it could be a pretty normal thing. It's not an infection though, and that's where the confusion often happens, is that you see red foot. If a red foot with absent pulses, you may want to lift it up and see if indeed that's what you're dealing with. So these are kind of the main ones. And then physical exam showing diminished pulses. And you all have access, well, Marlinton Clinic, I know you guys have access to an ultrasound, correct? A handheld Doppler. So you can always, if you feel pulses you're not sure, you can always use the wand and verify. But you'll see here the algorithm, basically getting a good physical exam and a good history. And then the next step is ABI. Like that's all this thing is, it's ABI and what to do with the results. So here you get your ABI, and there's a possibility of 3 different things happening. Either you get a normal ABI, which is around 1-ish, or you get an abnormal ABI, which is less than 0.9, and that equals PAD. Or they have diabetes and they have very calcified arteries, and so you get an abnormally elevated ABI, and that's where things get tricky, especially with people with diabetes. Just good to know, toe pressures are really what we look at. We look at the waveforms, and we look at the toe pressures in people with diabetes in particular. Because if they have flat lines all the way down, even if it looks normal, it's not normal. And so here they kind of talk about that a little bit. So if it's very elevated, then it's probably not an appropriate exam. Either the arteries themselves are calcified, or maybe they have a lot of swelling, whatever it is. And so if that's abnormal, the toe pressure abnormal, or you have an abnormal result, the answer is, again, guideline-directed medical therapy. So, and I'll talk about what that is in a second, but it's medical management, typically never intervention. Here are ABIs, here are the categories. Categories will be slightly different depending on where you work and who does your ultrasounds. But here's an example of the waveforms. This person has a normal ABI on the right, as looks like moderate disease on the left. See the waveforms are a little bit more dampened on the left side. And that's just, for your information if you get these studies. So here I did a little PAD or not guessing game for the group. So I'm gonna have, maybe I'll go back and forth between Marlinton and Green Bank for answers. But here, so 54-year-old patient presenting with bilateral leg pain, it radiates down the buttocks, down the leg, or it gets worse when they walk, improves when they walk with a shopping cart or when they bend forward. Is this PAD or not? I see Kayla shaking her head no. What is it, Kayla?
Could be like it's not sciatica, but some type of spondylosis or spondylolisthesis or something.
Yeah, mystery back thing. It's like, spinal stenosis technically, but exactly. It could be any of these kind of neuropathy, back pain things, especially when they're like, oh, I bend over and I'm doing better when I'm going down, that is most often a spinal stenosis or some sort of back pain. If they and that's where in the history, if you can get from them, well, do you have a history of back pain or any issues there? That's helpful. All right, PAD or not, a 65-year-old female that has aching hip pain and foot pain in both legs, happens with activity, sometimes happens with weather changes. But even though she's walking and it does come on with activity, it doesn't seem like it gets better really right away when she stops. It's like it kind of lingers throughout the day. It's achy, uncomfortable. What is this? Is it PAD or not?
Would also not suspect PAD too highly here. Probably more directly arthritic disease of, let's say, hips.
Absolutely. So arthritis, hips, knees. People can get arthritis in their feet as well, but I think the weather thing and it just kind of lingering and being achy is a good example there. All right, last one, PAD or not, 36-year-old, I didn't even put a gender, 36-year-old female with tightness and bursting in the left leg, worsens throughout the day, improves with elevation, and it has swelling associated with it. There's two possible answers to this one, but it's a PAD. I'm gonna pick on Kristen.
All right, sorry, my nurse is talking too, but it sounds like it could be, yeah.
Okay. All right, I'll send the message.
So do you think this one is PAD?
Right, thanks.
I'm gonna say yeah.
So I'd say 36-year-old is a little bit young, maybe, although again.
Oh, I guess I didn't see that.
That's okay. But I would also, so here is where we get a lot of like in between where people do have this like pain and swelling in the legs. And we'll see a lot of consults about that. And typically if it's, especially with this associated with swelling and worsening throughout the course of the day, and especially getting better with elevation, that's really because when we talked about the pennant rubor, like they get pain when you elevate somebody with bad PAD. It doesn't make it better. It never makes it better at PAD. So in this case, I was thinking about venous insufficiency, and that's where this bursting tightness. I know my resident, Paul, was also thinking maybe like a chronic compartment syndrome, which is definitely a thing too, but that'll be a very bulky athletic person that's doing a lot of sports. But most of our patients, would be more, they have these, heavy, these painful legs that are swollen through the day. So what is the treatment for PAD? And this is the whole deal. It's let's not let them die of a heart attack or stroke. That is the focus. Let's save their legs, but the thing that's going to be the problem for the vast majority of people with PAD, it's going to be their medical problems. And so antiplatelet, either a single agent with aspirin or Plavix is acceptable if they're, you don't have any non-responders. Statin, extremely important because of the pleiotropic effects. So it decreases inflammation in the walls of the arteries. It's not about the cholesterol only. So statins kind of do extra magic. If they can't be on a statin, you can do a PCSK9. You just have to figure out the insurance things, what you have to do to get there. And we do have a cholesterol clinic here. So if that is something you're interested in, we can hook you up with that. And then appropriate antihypertensive so that you're not causing consistent damage and stiffening of the arteries. manage their diabetes, and smoking cessation, very important. I bring this up, so this is from the 2016, or no, this 2021 circulation, looking at those guidelines that I just mentioned. This was brought up in 2016, published in 2016, that this is what you should be doing. This is what's actually happening. If you look at the literature and what people are actually doing, it's only 50 to 60% of patients are actually put on an antiplatelet. Only 30% are getting statins, and those are asymptomatic PAD, 61% if you're symptomatic. 48 to 60%. So they do recommend, ACE inhibitors and antihypertensive. Again, only a proportion are getting them. And the big one is the smoking cessation. That only 16% are getting counseling, 11% getting Chantix and other types of therapy. So we're just not quite doing what we need to be doing for these patients. What is the treatment of PAD with claudication? So let's say you have someone who has stable claudication. What do we mean by stable? They can walk, X amount. And it's always hard in a rural environment because all of the teaching is about blocks. So they're like, you can walk X number of blocks. And that's what you figure it out by. Are they not walking as many blocks, etc. But we don't really have blocks here. But they need you can kind of determine a distance. Maybe you talk about how many times you can get around Walmart, whatever it is. It will often stay about the same. That's stable claudication. If they become less stable as they're getting more severe, then their walking distance will change. So the treatment with the patient with claudication, the most important thing is a supervised exercise therapy program. And that is not something that's easily available. And so even if you can talk to them about doing something at home, that for our purposes is acceptable. We are working on improving access to SET. We don't even have it in Morgantown yet. We're working on it. But what we found is that people that have exercise therapy programs, supervised exercise therapy programs, so it's 3 times a week, 30 to 45 minutes, they need to walk until they feel the pain in their leg, because the pain in their legs is actually sending signals to improve oxygenation to the muscles. And so VEGF, all the chemicals start brewing and they start growing their collaterals by pushing into that pain. They have to make the pain happen though, and it sucks because it hurts. So patients have a tough time with it, but if you can get them on Fleetal, plus a walking program, that's going to have huge impacts. And we know that in 2 years, their quality of life is going to be so much better if they're able to stick to a walking program. And then there's a lot of other recommendations here for patients with claudication. The main things are quit smoking, statins, take care of your diabetes, take care of the blood pressure. Again, just antiplatelets. They recommend don't do warfarin, don't do a blood thinner for it. I know there is now new literature for DOAC, so that's a whole other talk. Don't use folic acid, vitamin B12. They don't recommend that. They do recommend a 3-month trial of sulostazole. So just some things about Fleetal if you've ordered it for anybody. I typically will have them do half a tablet for the first 2 weeks. So half a tablet BID for the first 2 weeks, because otherwise they get diarrhea from it. You can warn them they can get diarrhea. It will get better. They just have to hang on. They will not have, the same thing with the walking program. They're not going to have relief of their symptoms. It takes about 3 months. So they got to stick with it for 3 months. At 6 months, they'll have reached their maximum walking distance. So whatever improvement they're going to have, that'll happen by 6 months. And that will be their walking distance. And that's how far they're going to be able to walk. If they stop doing the walking program, that's going to decrease. But that's really the best thing for them as far as their overall quality of life. The other thing that can be done in claudicant that we really don't think is a good idea to do is interventions. So if someone has severe disabling claudication, they can't get to the mailbox, they can't go to the grocery store, they cannot do what they need to do in their life, that is a reason to do an intervention. But somebody like this guy, it was not the right thing to do. This is someone that came to me from Tennessee to establish care in 2019, 72-year-old, has risk factors, has PAD. He had about a 400-yard intermittent claudication that was bothering him, and someone gave him stents about 8 years and 4 years. So they gave him a bunch of stents. When he came in, he was on appropriate therapy, wasn't smoking, so that's great. But you can see here, so he had pretty good ABIs, 0.96, 0.92. No toe pressure though on the left. Toe pressures were crappy bilaterally, just at baseline. So some small vessel disease. In 2021, all these numbers have gotten a lot worse. And the problem is, once there's stents in there, you often have to do something if it's for claudication. So I did an angio, and I'm only showing you because this is what's bonkers. All of these arrows are where some guy came in and put stents. And let me tell you, these stent locations are not where they should have been putting stents. These are at branching points that you're not supposed to stent. So I had 14 stents placed over about an 8-year period. Still having claudication, so his symptoms are not improved. We're not being, taking care of them. And now I have to deal with making sure these stents stay patent, otherwise he's going to lose his leg. So these interventions beget more interventions. So unless someone truly fails a walking program, you should not be offering them, to a claudicant an intervention. And I want you all to know that, because there are a lot of bad actors out there that will do lots and lots of interventions. It's getting more media coverage now, but it's not the right thing to do with someone with claudication. You should not expect your patient that you send to establish care to be whisked away for a stent immediately, unless you've tried best medical therapy. So, and this is something that's well accepted in the Society for Vascular Surgery. Just in the literature, they looked at all the patients in the VQI, which is a huge number of people, all of the interventions happening in the country, and looked at people that had a stent or angioplasty for claudication in the VQI, which is the quality registry. So 16,000 people they looked at. 45% were current smokers, and 20% were being discharged without statin or antiplatelets. So clearly not getting medical therapy. And the deal is that about 50% of them had intermittent claudication recurrence and repeat procedures within 2 years after initial treatment. Only 32% were actually free from recurrent symptoms. So, and here's, fancy tables. Point is, what are we doing here? This is not appropriate care for patients. We're not making their lives better. We're costing a lot of money. And worse off, we're making them at higher risk for having a problem later on down the line. So they are more likely to get a reintervention, and they're more likely to develop chronic lymphatic ischemia when you start messing with them. So just in general, again, we're dealing with a chronic disease process. We revascularize, we do even bypasses, everything else. Aorta bifens, they do pretty well. Okay, that's 90% patency at 5 years. Some of these other ones though, when you start getting below the knee, we're talking about 50% at the knee, 33% for the synthetic graft. Like, these are not lifelong fixes. When people have stents, we're talking 6 months to a year of them staying open. So these are not long-term things, and that's why we save them for people that have wounds or rest pain. We should not be doing them on people that have claudication. So speaking of CLTI, so this would be an example of a time to intervene. This is a case I did with Dr. Kane, like way back when I started here, I think. I don't know if you remember, sir. It was a poor lady that was far away from care, stopped taking care of her diabetes, and had a long-standing wound that was kind of down on the tendon. I had 4 ABIs. We took her and revascularized her. So here you can see her SFA was occluded, put a stent, and she had reasonable flow down to her feet. Dr. Kane took over, did wound care over time, and was actually able to heal the patient. So that would be an example of an indication for intervention. Here would be a less urgent. So I just wanted to show you like 3 different cases where intervention happened and where it was indicated. So here's a patient that is indicated. He's someone that was recently sent to me by Dr. Hurst. He had this wound that was non-healing for months and months and months. It finally closed, but that thing's going to reopen. Absolutely. Bad ABIs. My plan was to angio him to see if I could improve him, but he no-showed to his intervention. So we're trying to track him down and get him to get some care. But this is someone that, he can get it done like in a month. Like if I see this guy in clinic, he has a closed wound, he can get it done in about a month. I don't have to whisk him away to the OR. That other lady with the gangrene and bones and things exposed with erythema surrounding it, that patient had to be done urgently. Here's someone who probably needs something more urgent. So this was a patient with end-stage renal disease, presenting with dry gangrene, and erythema. And again, this patient also was taken for an angiogram, which was a while ago, this one. But just so you see some pictures here. So here is the example of the thing I was trying to tell you about. What is this? Is this an emergency? We're just gonna play the emergency or no for a couple more slides and we'll be wrapping up. Anyone know what this is? You can put it in the comments. It's a thing I already asked the group about that nobody wanted to answer. Kristen said, oh. But I don't know if it was referring to those.
The dependent ruber.
Yeah, so this is a patient with dependent rubor. So this is a sign of PAD, but not necessarily an emergency. So if you elevate it, it should be the same color as the other way. How about this? How about this picture here on your left? Patient's right. Is this guy an emergency? Dr. Hurst is shaking his head. What do you think?
I say no, because it's dry, it's stable. It's not acutely infected. So something that can probably be done, like not like an emergency, but like certainly whisked away for an angio emergency type thing, like it is in the clinic. But not, I guess, in terms of like get transferred right away. Unless it's unless my picture's a little bit off, but
No, you're right. What about the guy next to it though?
that's something they're a little bit more concerned, because you got bulla, you have something developing there. That's certainly something acute changes. So there's certainly something going on that I would be certainly more worried about in terms of like emergency.
Yeah, this guy needs to go to the closest ER most likely, because that's some kind of wet gangrene. And so here's just kind of the difference between dry gangrene and wet gangrene. This guy definitely needs intervention, but this one over here needs to even be drained before any intervention could be done. This like perfect. Here's another emergency or no. Bluish discoloration, the toe. What do we think? Anybody else?
I'm
Is
trying to
this-
show blue toe syndrome.
No, I'm not trying to show that one, but that is a thing that if you have someone without just a blue toe that shows up, that's maybe an embolization from somewhere. This is more bluish hue, wounds, erythema. And this would be another example of a wet gangrene. This is a bad situation. This is more something you'll see in a diabetic foot where they maybe didn't feel it and it started to move quickly. This is the actual extent of the wound. And that's important for patients to understand, because a lot of the time we take someone and they're like, oh, I just had this little thing and then you took off all that. No, it's because the wound, it spreads very quickly in the feet. And so to explain that, here's something like a diabetic foot wound where they're not feeling it for a long time. This is actually how much of the wound is involved, because these things travel through the tendon sheets. This is a patient of mine that had a wound on the foot, person with a foot. This is, the tendon is an avascular plane. It does not have good blood flow. And so pus and infection can travel up it very quickly. That's where we need to decompress these things quickly. So this is just an example of an infection that spread. So they had to get an amputation of the level of the ankle. So just to sum it all up, PAD is a marker for significant cardiovascular disease. And there is a lot of room for improvement to take care of these patients so that we're following the appropriate guidelines. At this point, vascular surgeons are not meeting our minimum standards of efficacy for treatment. We're not doing any favors to these claudicants. In addition, so if we just intervene without trying to improve them medically, we're not doing the patients any favors. And in fact, they're at a higher risk for poor outcomes because they are more likely to progress to CLTI because they've had a bunch of damage already done by our stents and balloons. So appropriately identifying patients with PAD is going to save lives and lives. So we just need to get better at doing it. And I know I'll open it for discussion. I was just thinking of, why aren't we doing it? I think a lot of it is just that primary care physicians and APPs are not getting the education. I don't think that PAD is something that's prioritized in medical education. And so going into it, you don't have that. And patients aren't educated. Nobody knows what it is. And then we have some bad actors. And I don't know if you've seen the New York Times articles that recently came out, the ProPublica article that just came out, but we have people that are charging like $4 million a year to Medicare for interventions. it's about 1 to 3% of providers are billing the majority of Medicare. So it's a couple bad actors are doing way too many procedures. So that is something that needs to be addressed. All right, any questions?
I have a little bit of a question, just out of curiosity, to your knowledge, and have any of the the anti-diabetic agents that have upon release for diabetes found to have their benefits for CAD and heart failure? Is there any data suggesting those might have outcome oriented benefits for PAD specifically?
Such a
To
great
fit into that
question.
algorithm.
That's such a great question. There's not, to my understanding, there's not any information there. And that's a great point that, only 3% or something of all of NIH funding actually is focused on PAD. So there's not a lot of motivation for companies and researchers to study it. So the drugs are not studied for it. And that's why the Voyager study was so innovative, because they actually looked at PAD and we're trying to focus on that patient population. So that's a great question, that if we can include those variables, like if we can update the variables in the VQI to include that, I think we will end up, like over the next couple of years, getting a lot of real world data to see how they do. But that's a great question we should look into.
It's like Dr. Vince, I have a question. This is Catherine Lucia. As somebody who is a provider in a rural area, when would you like to see these patients referred to you? At what point in their disease do you think would be a good time to refer to a vascular surgeon?
I think once they have claudication, I think it's worth referring so we can get an ABI, and then typically we just see them once a year and make sure they're on the medications. Just making a diagnosis of PAD in someone who's asymptomatic is probably not somebody that we need to see.
Hey, Sam, it's Rusty here. Hey, quick question. When do you decide, or what's your criteria, like just doing like an angioplasty, opening somebody up versus placing the stent?
That's a good question. So typically in a patient that has we start with angioplasty on everyone. You have to angioplasty them first. If you're dealing with like a chronic total occlusion of an artery, and you don't have a very satisfying result from your angioplasty, then you will put a stent. So usually it's like if there's recoil of the lesion, you don't have a nice result, or it was an occlusion, so you had to dissect into the arterial wall to get into it, you do need to put a stent. With the drug-coated balloons, there's been a big shift because they seem to be so effective with keeping things open that there had been a decrease in stenting, but then with some questions about the outcomes of patients, increased mortalities of drug-coated balloons, which I think it's been put to bed, but I think that kind of decreased enthusiasm. Anyone else? I know we have Dr. Hurst's presentation. I don't want to step on.
Okay. Thanks for the questions. Thanks, Sam, for the talk. We actually have one in the chat here from Ranjita. How do you educate patients about this?
I'm gonna send that question to the group. We need to do better. We know PAD also impacts people of lower socioeconomic status and lower education levels. That is known. So we're dealing with a population that is a very vulnerable population. And it's hard to get them involved in research. We've had, I've been part of associations that have tried to get PCORI grants and try to get patients with PAD to kind of tell what's important to them to come up with research questions. And they found some very educated people like in California. That was about, a couple places, major places. But they were really outliers. They weren't representative of the usual population we deal with. Right? I mean, as we learned from our discussions with our clinics here, you know, the ones that really need it are the ones that don't come in or the ones that have refused to have the care. But we're also looking forward to Dr. Meeser's talk about behavior and trying to convince patients to do the right thing for themselves. That will be coming in November. Should we
Good.
have Dr. Hirsch bring up his screen?
Yeah, so he should be able to, yep, there we go.
Okay, can everyone hear me?
Sure can, and we see your slide.
All right, perfect. Okay, so I thought it would be great to talk about, and it's going to take a little bit of a shift away from the PAD, but I kind of wanted to do this case presentation as something that we saw here, you know, when we first started here at Elkins, is that, you know, something that can be shown to really help with like identifying things early. And I think that's the most important thing, I think, with these echo sessions, is trying to like, when does something need intervention or when does something need to be seen? So this patient, she's a 60-year-old female, history of type 2 diabetes, complicated by neuropathy, history of asthma, hypertension. So she presented to the floor from an outside hospital for concern of a left foot infection. She states she noted the last few days from some bruising to the plantar medial aspect of her left foot. She also has a history of losing her hallux nails, and she's been soaking in a vinegar solution. She's a nurse that works 8 hours a day, and she has difficulty with ambulating due to the pain to her left foot. She did have a trauma that was remote about 2 months ago where she fell on an uneven step. She states that it's been red, warm, swollen, and it resolved a little bit on her own, but she never considered it problematic. She was placed on an oral antibiotic by her primary care because they evaluated and felt it was consistent with cellulitis. And then she was scanned for a blood clot by the emergency department at the previous hospital, which was negative. And then they finally admitted her secondary to cellulitis, and she denies any constitutional symptoms. In terms of past medical history, we stated before, asthma, type 2 diabetes, hypertension, her home medications are in line with her past medical history. In terms of physical exam, she had diminished protective sensation by Sims-Weinstein monofilament. Light tension sensation was also diminished. She had some tenderness to the plantar medial aspect of her left foot. There was edema, most notably to the left side, especially at that increased bony prominence of the medial foot. 5 out of 5 muscle strength, pain-free range of motion in terms of the ankle and subtalar joint. Compartments are soft and compressible. In terms of the left side, certainly more swollen than the right side than the contralateral limb. Normal texture and turgor of the skin. There is no increase in like areas of hyperkeratosis. There was a little pinpoint lesion. I have some clinical photos here as well, but most notably is the erythema to that medial and plantar aspect of the foot with warmth associated with that area, especially compared to the contralateral limb. In terms of a vascular perspective, her pulses were palpable. Cap refill was less than 3 seconds to the digits, and there was moderate edema to that left foot, especially compared to the contralateral limb. So looking clinically, it's a little less impressive with like the washed out appearance of the light, but she certainly has this protuberance to the plantar medial aspect of the left foot. On stance, you can notice that there's like a little area of like hyperpigmentation. That's most notably where she stands when she is weight bearing, but she was concerned about all the redness to this area of her foot, the warmth to the area, and everyone that kind of saw her was concerned for a cellulitis, some sort of infection to that area. You can take a look at the bottom of the foot, but you can kind of see like how she's getting a little increased area of pressure, but hasn't developed to anything worsened yet. So I kind of open it up to like a little echo pause. If no one wants to, we can always move on, but what would be some people's like next steps with this?
Go ahead, Quentin. See you unmuted.
Yeah, I'd switched screens, so I missed a couple of first details, but did we get plain films?
Great. Yeah. So we got labs and we got plain film. So just to start off with the labs, leukocytosis, there was no leukocytosis. WBC is 8.2. She had a CRP of 1.95, ESR 32 with an A1C also of 11.3. She did have some plain films that were obtained, and you can see that there's some homolateral dislocation with debris. There's distension to the area of the joints. There is also that lateral displacement at the first TMT and medial displacement at the navicular cuneiform joint. Most notably, when we look at the lateral, is kind of like our most distinguishing factor, but you can see this destruction, debris, dislocation, all present throughout this area of that middle of the foot. You can see almost like a sagittal fault. On her weight-bearing films, which were done like previously before, which I couldn't get access to, but she also had a negative cuboid height in terms of like on her weight-bearing films, negative Meary's angle as well. We also got an MRI was also obtained at the outside hospital. So they were concerned for like possible infection, especially an osteomyelitis is something that always came up, but she has no history of wounds. So what we look at is we have multiple images here that are kind of scanning through is that these are T2 and T1 weighted images. And what you can see most notably on the T2 is you see a lot of increased signal intensity throughout the middle of that foot. You can see that it's in multiple bones and multiple areas of the foot, which is, and now you can see like the T1 weighted images here on the upper left. But the big thing is that, you know, differentiating this between like what would be some people's like idea in terms of a assessment for this.
We have a couple of things in the chat about the X-ray. Catherine mentioned that as you're getting into that, Michael.
Mm-hmm.
Can you see the chat? Do you need me to?
Can't. How do I see
Does
the
it?
chat with me?
That's okay. That's all right. You can, if you look where you shared your screen, right next to it, there should be a chat button.
Oh, there it is. Perfect. Okay, cool.
Yep.
Great. Yes. So Charcot is certainly on our list for in terms of our assessment. So we look at, in terms of our assessment, is going to be midfoot Charcot neuroarthropathy. Now, this is in the acute stage because we have findings consistent with not only the destruction on radiograph, but she's also consistent with increased warmth to the area. She has swelling. All these findings are consistent with the acute stage of Charcot, which we're going more in line of rather it being like an active versus inactive versus like our different stages in terms of like Eichenholz and our location stages based on Brodsky. So a lot of our ideas are going more into active and inactive. Certainly history of the type 2 diabetes. Now, for her, I kind of included the plan of what we did for her. And if I'm going to add into the chat here, just some of the risk factors in terms of percentages of people with Charcot neuroarthropathy. So we look at like development of ulceration rate. Depending on what literature you look at, it can range from 34 to 64%. And when you talk about like Pinzer's article, you look at, 60% of people with like a midfoot Charcot neuroarthropathy don't develop any ulceration or need any surgical intervention. But the problem is when they have this frank dislocation, you look at the cuboid height. That's one big thing that Wukic looked at University of Pittsburgh Medical Center. Usually typically like -5, looking at that, they're at an increased risk of ulceration as well. So the argument becomes is when do you do something in terms of intervention to help prevent this thing? Because when you start to look at the major amputation rates, they can be as high as 14 to 37% for people with a Charcot event to that side. The 5-year mortality rate increases with people with Charcot to 29%. And the biggest thing is how can we develop and make sure that we prevent the development of ulceration? Because then our major amputation rate in terms of 5-year mortality increases 56%, because that's our whole goal is we want to prevent the ulceration rather than kind of hope that we don't. So we're a little bit more aggressive in our mindset with the acute Charcot in terms of like literature. There's only like really 2 articles that look at acute Charcot, Simon and Mittelmeyer. We have an article published that's kind of in acceptance limbo right now, but we looked at 30 acute Charcot events and actually, in terms of like frank dislocation, something that would be a great idea of terms of like how we can make preventing that ulceration is by doing some sort of reconstruction. So for her, This is something that we put in like an external fixator. Typically, we like to use an external fixator first for procedures like this because with her A1C so high, she's at a high risk of infection, and we can able to reduce that deformity to help with to have a better stable midfoot. So we have some x-rays here, but you can see now a vast improvement in terms of the alignment of the foot. You can see now we have a normal Meary's angle. That cuboid height now is above the level of the calcaneus. So we're certainly at a better opportunity in terms of, okay, like how can we make sure that this does not prevent an ulceration? Now, I'll kind of like not speed through this, but kind of keep going through, but you can see now a reduction of that frank dislocation of that foot. Typically with these people though, is that we keep the X-Fix on for typically 2 to 3 months or so while the A1C goes down. If they have a history of ulceration, that also like tends to stabilize them. And the reason we use a frame is because in that acute period, you learn about the progression of Charcot. It goes from a very malleable, destructive bone, and then as it goes and ages, in terms of our stage 2 and our stage 3 of the Eichenholz, it starts to become more sclerotic. It becomes hard, and then then you're in a deformity that you have to do a lot more work. It's a lot less malleable to be able to put in a better position. But typically with these people, we typically will remove the external fixator, and that's something you can do in the office, which is nice because they're neuropathic. But you can see a great improvement in terms of her foot, in terms of from a lateral view, that no more sagittal fault, her Meary's angle is normal. But typically with these people, they need some sort of further reconstruction because this is going to be something that comes back. So typically with that, we end up actually fusing their ankle, because when you look at like principles in terms of constructs, typically you want to stray away and expand past the areas that are involved in terms of like a super construct. Now, not necessarily 100% of the super construct principles in terms of San Marco, but typically we like to fuse that ankle, because when you look at like literature in terms of like Shibata, who actually first described a stage 0 Charcot, which is a red hot swollen foot without any clinical signs of Charcot. Typically when you fuse the ankle, you have less progression throughout the area of the midfoot. So that's kind of like our principles and what we kind of look at. But now she has in terms of, this is her last x-ray, which is in terms of like how she is doing, but a little bit dynamization there. She has some fusion across the areas, but now she has like a stable foot that she can ambulate in a plantar foot and put a shoe on. And she doesn't have to like wear a crow for the rest of her life or some sort of orthotic device, but she can wear and ambulate in a regular shoe. Usually with these people, I always tell them it's a long time in terms of like when this is going through. So it's about 7 months before they're even like beginning to think about walking. But I just wanted to present this because this is someone that presented with a red hot swollen foot. A lot of people thought it was cellulitis. A lot of people even thought it was a blood clot. She went through multiple things where no one got an x-ray until she was finally admitted and transferred here. So I think like in terms of being like a first line thing, if you see something that's out of the ordinary, I don't think you're in the wrong by being overcautious, getting x-rays, getting this laboratory work, working up this patient for something, because you look at some of the literature, a delayed diagnosis of Charcot is very high, and it makes a lot of jobs of myself and some of these other providers to be a lot easier when you can get them a lot earlier. So that's just kind of something I wanted to present, just to kind of keep people aware of this, and something that can come up and you see, because you're going to be the first ones that see it. Because when people have a red hot swollen foot out in these like rural areas, they're going to go to their primary care. So. If anyone has any questions, I also had this available, but this is kind of like description throughout about Shibata's article in terms of like a stage 0 Charcot, which is most likely what you'd be seeing, but it's usually a red hot swollen foot without x-ray changes.
Well, I look forward to you teaching us more about this during your talks, because I'll be honest, I am a vascular surgeon. I've had zero education on what Charcot is throughout my fellowship. It's only as an attending. So for our primary care providers, I don't know, I understood like a quarter of everything that just was said. So I'm really looking forward to learning more about it. I mean, I know Charcot, you got to get into a podiatrist and they got to do stuff to it, but that's my understanding. So, but my favorite part was that she had pulses, because that took me out of the equation. But that's we worked on a patient that had like no pulses. I had to do a bunch of angios and stuff just so that we could heal the Charcot stuff. But we are we are out of time. I'm gonna send it back over to Jay and just beg all of you to please fill out your evaluations because we need it for the.
Yes, yes. Oh, Brittany, do you have a question? Just unmuted. Let me see. Okay. Yes, so the evaluation, so there's, first of all, Michael, thank you so much for doing that. Everybody will have access to that PowerPoint of his through the iEcosystem where you logged in. So, feel free to go through that. And obviously, like Sam said, he will be bringing this topic back up when he speaks, which is great. But yeah, the evaluation link is very important. So there's two different evaluations, unfortunately. For your CEs that we offer for the sessions, that's done through the Office of Continuing Medical Education at WVU. They have their own survey that they do once a year for your credit. That is something we don't control. And unfortunately, that's the way they do it. So what we're asking and what is in the chat is for an evaluation of this session right now. And so that's what's going to happen every month is you'll get a survey in the chat, a survey link in the chat, and also in the recap email asking you to fill it out. We appreciate the feedback you can provide. It's going to help us mold the sessions further. And this is really for you guys. So we want to hear what you have to say, what you like, what you didn't like. So please fill it out at any time. But that's how we didn't really get into that last session. I apologize, but that's the difference. CE, you guys are still getting the CE credit. I'm still turning the stuff in for everybody who's joined. It's just that you're not going to hear from that CE office until one time. And they're going to ask you for all your feedback on all the sessions you attended. Again, I know we're recording this, but I don't really care. I don't really agree with that, but that's just the way they're doing it. So if you have any questions on that, please let me know. I know it is confusing. If there's not anything else for the good of the group, I'll stop the recording because I know Sam, you wanted to make a couple of announcements. Am I correct on that?
Yeah.
Okay.
I mean, just our
Okay.
main thing, yes, that the NIH funding